Hello everyone, this is my thesis topic, investigating the accuracy of artificial intelligence used for caries diagnostic. My name is Bruna, I'm a dentist, and my supervisor is Martin Kivovic, and my SMS is Alex. My vision is making high-end dental diagnostics accessible to the public, and my mission is applying artificial intelligence for community dentistry. Here we can see my specific goals. The first one is investigating the accuracy of artificial intelligence used for approximal caries diagnostic. The second one is investigating the accuracy of intraoral scanners used for caries diagnostic. For the first project, we performed a systematic review and a meta-analysis. And according to our background, the direct cost of dental caries is more than $200 billion a year, and the caries is still affecting people population, especially approximal caries. And considering bilingual radiography as standard, to have a good accuracy can reduce the complex cases and avoid the teeth loss. In addition, the literature shows disagreement between experts about caries diagnostics on bilingual radiographies, with a sensitivity range between 0.5 and 0.7. On the other hand, artificial intelligence can improve the early detection with a sensitivity ratio of about 0.85. That's why our aim is investigating the diagnostic accuracy of artificial intelligence for approximal caries lesions on bilingual radiographies. Our clinical question is, what's the accuracy of artificial intelligence used for approximal caries diagnostic on bilingual radiographies? As population, we chose patients undergoing bilingual radiography as index test, artificial intelligence, as reference test, express consensus, and as diagnostic the accuracy. For our systematic search, we chose for the first domain bilingual and for the second one caries. According to our flowchart of selection, we have 14 eligible full texts, and 6 were used as qualitative data and 8 as descriptive data. Here we have our final results, and we chose as outcomes sensitivity and specificity. Both are important to understand if the index test is equivalent to the reference test. And here we have 6 RCTs that evaluated artificial intelligence performance using express consensus as reference. And as we can see, the results favor artificial intelligence, especially the sensitivity that were above the expert's threshold. Regarding the predictive values and the likelihood ratios, I would like to call your attention for the negative values. As we can see, the negative predictive values were moderate to high, and the negative likelihood ratios were low. That means artificial intelligence has the strategy of excluding true negative answers. And also, the positive likelihood ratios were above 1. That means artificial intelligence test is good, as is efficient. For the predictive values and the given prevalence, we can see there is a relationship between them. When the positive predictive values decrease, the prevalence decreases too, and the negative predictive values increase on the other hand. In the study level table, we can see the DOR. The DOR means the diagnostic odds ratio, and it's regarding the performance of the index test. And here we have 2 of our best results for artificial intelligence. We also can see the prevalence, that's regarding the total number of caries found in the sample. And here we have 3 of our best results. Of course, the studies that used huge sample sizes. Here we have the HS rock plot. This is a hierarchical summary of the accuracy. And as we can see, most part of our articles were included in the confidence ratio. We also can see how high is the heterogeneity, what can be explained by 3 reasons: the different sample sizes, the different artificial intelligence models, and the different machine stage of learning. As strengths, we would say this is the first meta-analysis about the topic, and we only included RCTs and non-RCTs. As limitations, we would say the fuzzy gold standard, the low quality of reporting, and the lack of raw data that made it impossible to compare the accuracy between artificial intelligence and experts. As conclusions, we say artificial intelligence sensitivity and specificity are high to detect approximal caries lesions on bite-wing radiographies, and according to the negative predictive values and the negative likelihood ratios, the strength of artificial intelligence is to exclude 2 negative results. As implication for practice, we advise artificial intelligence should be used as a preliminary step, followed by experts diagnostic. As implication for research, we say trials reporting should be more transparent, and the raw data should be available, and the ground truth should be established. Our manuscript is done, and it was already sent to internal review last week. And for our second project, we are going to perform a systematic review and a meta-analysis as well. And according to our background, more than 500 million children have untreated dental caries in primary teeth in the world. And the introduction of intraoral scanners can support the clinical decision and avoid the teeth loss. The process is very simple. The expert starts scanning the patient's mouth, and where there are the mineralized tissues, there is more water, and the water reflects the infrared light of the intraoral scanners, result in a bright area with the shape of the lesion. That's why we can say intraoral scanners result in equal or improved sensitivity in comparison to bite-wing radiographies. Our aim is investigating the diagnostic accuracy of intraoral scanners for caries lesions. Our clinical questions is what's the accuracy of intraoral scanners used for caries diagnostic? As population, we chose extracted teeth as index test, intraoral scanners as reference test, the histological assessment, and as outcome the accuracy, with the clinical implication that intraoral scanners can increase dentist's diagnostic accuracy and avoid the teeth loss. For our preliminary search, we chose for the first domain intraoral scanners and for the second one, caries. We are in the very beginning of this project, still working on the Prospero registration. And in summary, we plan to submit the first article in this month and the second one on September of this year. To finish my presentation, I would like to say a Paulo Freire quote: education is an act of love and therefore an act of courage. You cannot fear the debate, the reality analysis. You can't escape the creative discussion, otherwise it will be a farce. Thank you so much.
I have just a very simple question concerning your research implication for the first project. What does it mean, ground truth? Like, how do you mean it? I didn't understand. Thank you.
Thank you for your question. It means something that can be used as a reference, some kind of measurement that can say this is really a carrier, because as you saw, we have a fuzzy gold standard as experts' consensus. It's very, very subjective. You can have an opinion, I can have another opinion, so you really need something that is established, that can be used as a standard. So this is named a ground truth.
And thank you. And for the second project, you have the caries as a diagnosis. any specific type of caries? As for the first one, you have approximal.
Thank you again. We plan to do subgroup for them, approximal caries, occlusal caries. So we have a general type of caries here. So I think the pretty advice is to subgroup it.
And I'd like to ask you if any of your studies include the types of intraoral scanners they are using for their studies, or it's not relevant in this?
Sorry, could you just repeat the end?
Yes, is it relevant what kind of intraoral scanners they are using, or?
So we are in the very beginning. So now we didn't decide if we're going to subgroup it and include different types. But if it is going good, we are going to include. Thank you.
Okay, thank you.